Hello friends, I am Dr. Praveen Gupta and with me is Dr. Jai. Today we'll be talking about the next pattern of MCQs, and because the basic need of today's era is to know the vertical indication of the topic. That means when you know pathology, you should know the surgical management as well. So in that regard, we have come with a very high-ranking topic, that is the breast lump. We have got a question that actually came in surgery. I'll request Dr. Jai to go through the question, please.
Okay, I'll go through this question, Dr. Praveen. The 50-year-old female comes to you with a complaint of breast lump for 6 months, which is progressively increasing in size over this period. On clinical examination, found to be variable consistency lump of size 4 by 3 centimeter. On axillary examination, there is no palpable lymph node. True-cut biopsy was done, which shows the following histological feature. What is your diagnosis? Is it a surgical question? It's not a surgical question, Dr. Praveen.
So there were some questions asked on this. Let me just show you the question. This is the question that is asked.
No, for me actually, come back. For me actually, it is all blue and pink. What is it here?
This is actually histology given to the students in the last few months, and that's quite true, friends. Looking at this histology, everything looks blue and pink.
Yeah, actually, when I was in my undergraduate level, Dr. Praveen, let me tell you, we used to have, have a technician, who is known to us. He used to give us the numbers that on this slide, this number, there is this slide, and on this.
So we already knew that the microscope had question number 1 is histological carcinoma.
Yes. So for us, it is all, and for all the surgeons, let me tell you, it is all blue and pink.
Right. So, okay. Anyway, so let's move to the basic understanding of the entire question. There is a breast lump, and that the clinical examination shows a hard consistency or variable consistency lump. But more importantly, unless you don't know the histopathology given at the back, you will not be able to diagnose the case, and henceforth you will not be able to manage the case. The problem with many of the students is because they don't know the actual and normal histology, that is first year histology, histopathology becomes very, very tough. So let's have the basics, sir.
Yeah, obviously, because again, without knowing the basic, I would like to learn it from here actually, because without knowing the basic, I will not understand what is it actually. So please tell me what are the basic, and the students also probably should know.
Let's understand,
what's the basic thing here.
Guys, let's start with the first year histology. So I've tried to make the basic histology of the breast here. What you notice here is there is a major duct here. There's a major duct which opens into the large duct here, and this large duct will open into the terminal duct, right? The terminal duct here, as you see, this is a terminal duct, and this terminal duct opens into this whole thing is called as lobule. Okay, and in the lobule, I have drawn this 1, 2, and 3. These are called as acini. They're like grape-like clusters. Okay, so what do you just imagine, that entire grape cluster is a lobule, and the entire grapes, the small grapes you see, are the acini. So a single lobule can have multiple of this acini all clustered together. Around this area, look at this gray color area I have tried to draw, and this gray color area is called as intralobular stroma, and the entire stroma all around it here, this area is the interlobular stroma. Now, why should we know this? Guys, what happens is there are some lesions which come from this major duct, and some lesions which come from the large ducts, and some lesions which come with a collective effort or collective, I'll say, anatomy of the terminal duct and lobular unit, and therefore called as TDLU, terminal duct lobular unit. There are some lesions which don't come from the ducts, they come from the stroma. That's a gray color stroma, right? This is a gray color stroma. Now, anatomically, if you look at these lesions, look, this is the normal histology of the breast, normal. What you notice here is this whole thing, this large here is the terminal duct, okay? And look, this whole thing here is the grape cluster. This whole thing is a grape cluster. And the small things you see here, this small one, okay, these are the individual grapes, and that's what we call it acini, right? So this whole thing is the lobule, and the small things you see here, the small, let me draw it in a bigger area. Look, this is the whole area is the lobule, and the small one here are the acini. So the whole thing together is called as terminal duct lobular unit, TDLU. The question is, why should we know this? If you look at this in a greater detail, this is the terminal duct. The whole thing here, this whole thing here is a lobule, and the small things here are the acini. What happens is, some of the tumors, they occur from the stroma between this, like this pink color stroma here. So all the pink areas are here are the stromas, and all the blue cells you see here are the cells. Okay, so sometimes the tumor comes from the stroma, and sometimes the tumor comes from the cells. So any tumor which comes from the stroma as well as the glands is like example is fibroadenoma and the phyllodes tumor.
Yeah.
And some tumor, they come from the glands, like the invasive ductal carcinoma or the carcinoma in situ. That simply means, suppose I show you an image which is limited to this gland. Inside it, it becomes in situ. Suppose a tumor
Once it
goes,
invades the basement membrane.
yes, it goes outside it becomes invasive
stroma,
ductal carcinoma.
From the duct, if it is coming to the stroma,
it becomes
an
invasive ductal carcinoma.
So now I'm understanding.
Right. So now if a tumor comes from not from the cells but the stroma, this stroma, pink color stroma, that is called as phylloids or the fibroadenoma, which we will not be discussing right now today. Now, having understood this, any lobule always has a dual ductal system, dual cell nature. That means, look at this big cells here. So if you look at one of the asinine cut section, the inner cell is called as ductal cells, and this dark cells here, you see this dark arrowhead cell, this one, it is called as myoepithelial cell. So what happens, the myoepithelial cell, it compresses the ducts and the milks come out, right? So what you can imagine is this whole thing is a ductal cell, and around this there are myoepithelial cells arranged like this. The myoepithelial cell will compress the ductal cells and the milk ejects out. Why should we know this? So just beforehand, we had shown you some images like this one, and it looked very, I'll say, astonishing, tough to you. Now, if you look at this carefully, what you're seeing is these all blue cells here, these are the very dark looking cells. And if you look at this carefully, look at this dark figure here, this dark one, this dark figure here, I'll just show it in detail again. Look at this dark cells. Look at this dark dot, or this dark dot, this is called as mitotic figures. So whenever a tumor is showing you multiple of these mitotic figures, and if you look at these very dark looking cells, these cells are showing you pleomorphism, hyperchromatism and the high NC ratio, and these tumor cells have invaded not on the glands but they have reached the muscle. Look at this dark pink area, this is a muscle. Why will a tumor cell from a gland move into muscle? The reason is the cells have invaded the basal membrane and they have entered not the stroma but they have invaded the muscle layer. Therefore, this is a classical example of showing you invasive ductal carcinoma. So, sir, there are two reasons of calling this carcinoma. First reason is, look at the number of mitotic figures, the dark, small dots, number one. Second, look at these dark cells you see here. The dark cells are showing you hyperchromatism, pleomorphism and high NC ratio. And thirdly, the tumor cell have almost invaded the muscle layer. So these are glands.
So it is now invasive.
Exactly. The gland should not be in the muscle. The glands moving into muscle means it has something is grossly wrong. And for me, therefore, it's invasive ductal carcinoma.
Sometimes, Dr. Praveen, there are various carcinomas like colloid carcinoma,
right.
And then there is medullary carcinoma also. There are special type carcinomas. Right. So how to make out those type of carcinomas on a slide?
Right. Sir, what happens is most of the morphological diagnosis is called as not otherwise specified, called as NST. So when you talk about the classification of the invasive carcinomas of the breast, we call it ductal carcinoma and we call it special types.
Special types.
Right.
If those special types are
not seen,
then we say it is not otherwise specified.
Not otherwise specified. NST.
Yeah, NST.
Right, NST. So moving to that pattern, see what happens is, there's some pattern of image I'll just try to show you. Like, look at this one. So these are special type of carcinoma. I'll just enumerate them if you want to know that. This might come in the future MCQs also, like lobular, medullary, metaplastic, apocrine.
This question has come also, Dr.
Right.
This colloid, I think there was a
There's a need to educate question, right?
This was a question, so I think this is important.
Very important, right? Yeah. So what you see, friends, there are many special type of carcinomas. These are like lobular, medullary, metaplastic, apocrine, cribriform, tubular, inflammatory, colloid, papillary, micropapillary. There are numerous type of these carcinomas. But if you don't get this special type, you call it no special type. In fact, sir, the no special type is 90% cases.
Yeah, it's the most common type of carcinoma.
Right, exactly. And these all collectively are just 10% cases. So I would just like friends to see some of the common types. Like, look at this first one. In this first one, if you look at, these are the pleomorphic malignant cells, and what you see around them, these blue cells here, these are the lymphocytic infiltrates. So what you say is a uniform pattern of cells, but you see the no gland formation here. That means there is no glands. The gland is not there. That means it is not a very good tumor. But having said that, look at this lymphocytic inflammatory cells. This is called as the medullary type. Okay. Now look at this pattern. In this pattern, you will be able to appreciate the round things. The round things actually are like the finger-like projections. Okay. Look at this one finger. Look at this elongated figure. Look at this another elongated figure, and look at this elongated finger-like projections. So these small finger-like projections is called as papillary type. We can also call this micro papillary type, right? Apart from this, there are two others. Like you look at this enormous amount of colloids, sir. I think this is the easiest to identify, and therefore NEET came up with this simple question this year.
Yeah, this was the question.
This was it's the same image that came this year. It is a huge amount of enormous amount of colloid that is filling up here. This white area are all the colloid cells. Therefore, it's colloid type, right? And there's one special type called as lobular carcinoma actually. So, sir, you might have heard about something called as CDH.
Yeah.
Right, CDH. So that CDH is a gene which codes for E-cadherin. So basically what this happens is, there are the two cells, and any two cell in our human body is actually linked
to each
by E-cadherin. Now suppose me and Dr. Jai are linked with E-cadherin. Let's hold a hand, sir. This is E-cadherin, right?
Yeah.
And suppose the E-cadherin is not there, we'll lose our hand. So basically we both lose our cohesion, we become non-cohesive. We just lose our attachment. Actually, what you're seeing here are all the non-cohesive tumor. Look at this. Cell number 1, cell number 2, cell number 3, cell number 4, cell number 5. They all have lost their attachment and lying in a single straight line, just like Indian soldiers stand in a single straight line. It is called as Indian file pattern, a characteristic image you see in lobular carcinomas.
This is a very important image.
It's a very important image. And sir, because they are very, I'll say non-cohesive, the risk of invasion is more. Because they already lost their connections. The risk of mets is very high. In fact, this is the one tumor which obviously presents with the unknown primary tumor in the other breast.
That is why it is many times it is
bilateral tumor, right? It's mostly a bilateral tumor. So basically,
it's
multicentric also because they already lost their connections. So they are free to go anywhere they want to. Yeah. So friends, try to understand that if you don't get the special type, this one is Melry because of the syncytial cells and the lymphocytes. If you don't get micropapillary, if you don't get colloid, if you don't get lobular, it may be called as no special type. So if you come back to the primary question we had, let's come back to the first question that we had. That's here. This question is showing you no special type, and hence I will call this invasive ductal carcinoma, no special type. I have diagnosed the case. Let's, sir, manage it.
No, Dr. Praveen, yeah, obviously before we manage this patient, we'll need to have a staging of this patient, and then we need to go through a metastatic workup. And in that metastatic workup and staging, I would like to know about the ERPR status of the patient also and HER2/neu status of the patient through the TrueCut biopsy itself, so that I can plan my further management. Right. So through TrueCut biopsy, we can comment on ERPR status and HER2/neu also. And depending on that, we have to have the management. So can we make out on the basis of slide that why it is HER2 positive or HER2 negative?
Right.
Yeah.
Exactly, sir. You know, the classification of any breast cancer is done in two ways. One is the molecular classification, that is ERPR and HER2/neu, and one is the histological classification. So what I just discussed before this was all about the histological classification, right? But there's some other type of classification done, and that is on the lines of the staining. So staining is done often in the ER, PR and the HER2/neu. ER stands for receptor of estrogen, PR stands for the progesterone receptors, and the HER2/neu, you all know it is called as EGFR2, epidermal growth factor receptor 2, also called as HER2/neu. Okay, so what happens? Let's understand how to diagnose these things. Whenever you look at the ER or PR, always look at the nuclear staining. Don't look at the membranes. So if you look at this one, look where the staining is there. All the staining you see here are in the cells, nucleus. And therefore, I will call this ER or the PR positive. So ER or the PR positive will be talked about on the immunohistochemistry. What we do is we take different slides and we take the antibodies tagged to the different antigens. Okay. And that antibodies tagged to the dye. So look at this. This brown color indicates the positive and the light brown area is the negative area. So because the ER or the PR is coming in the nucleus, I will well call this ER positive. And if this slide would have progesterone receptor, I will call this PR positive. So ER or PR stains in the nuclear area. But there's a big but there. Look at this one. This is not a nuclear staining. It's a membrane staining. Membrane staining is seen in HER2/neu. So this is a very common mistake that students do. Suppose the staining in the HER2/neu would be in the nucleus. I cannot call this positive, right? Now, if you understand this is say ER positive and the PR positive, and let's say this is HER2/neu positive. Often the HER2/neu positive has some sort of classification done. In terms of the staging, like stage 1, stage 2 or stage 3, not staging, is grading actually. 1+, 2+, or 3+. If less than 10% of the cells are positive, I'll call this 1+. It's straight away negative. if more than 10%, if 10% of cells are strongly positive, just 10%, it is 2 plus. But if almost 90% are strongly positive, I will call this 3 plus. That means if something is less than 10% positive, it is 1 plus, is almost as good as negative. Let's call this negative. If 10% are strongly positive, you are in a doubt. It can be positive, it may be negative.
So there comes a role of fish, I think.
That is where we do our fish.
So this is a question, actually, you must be aware of all this, that there was a question that a patient has a HER2 new status of 2 plus.
2 plus,
so
right.
What will be your next step?
Exactly.
So that means we
So
have
2
to
plus
go
is
to now
equivocal.
a fish now.
You have to do a fish.
Yeah.
So 2 plus, remember friends, is equivocal. You cannot say it is negative, you can't say it's positive. So 1 plus is negative, gone. 3 plus is positive, done. But 2 plus is equivocal. You have to do a fish analysis for the HER2 new amplification studies, right? So what happens is when you stain this like ERPR and the HER2 new, you have some grading done. So if there is ER positive, you can call this the luminal type.
That's a molecular
classification done, exactly. And if you get the HER2 new positive, it is the HER2 new, the second type, HER2 new positive. And the third one is ER negative, PR negative, and the HER2 negative. So let's assume, sir, that this case was actually ER positive, was PR positive, and was HER2 new negative.
Okay, so now you have given me the information that it's an invasive ductal carcinoma which is not otherwise specified, and with ERPR positive and HER2 new negative.
Right.
So that means now I can, we have a lump in front of me. This lump is of 4 centimeter in size, with there is no lymph node in the axilla.
Right.
So since there is no other information provided, I'll take it as there is no metastasis also.
Right.
So I would like to do the staging here. So now I'm in a right position to do the staging, and in this staging, since it is 4 centimeter with no lymph node and presuming that there is no metastasis because it is not mentioned, so we'll take it as M0. Whenever the patient comes to us also without any complaints, we'll take it as M0.
Right.
So we'll take it as stage 2. So with this, to decide about a further line of management, first of all, we need to know how to stage the tumor. So 4 centimeter lesion with no lymph node in the axilla with no distant metastasis comes to in stage 2. Now, for management of a patient of stage 2 malignancy, we have an option of BCT. We have an option of the modified radical mastectomy. Now, depending on whether the contraindication is there or not there, we will decide whether we should do a MRM or we should do a BCT. Now, once we have done a MRM, again, we would send the specimen to the pathologist, and we would like to know again for sure that what is the margin status of this specimen, whether the margins are positive or the margins are negative. And again, we will, since we have to do a lymphadenectomy also, depending on sentinel lymph node biopsy. When the lymph nodes are not there in the axilla, we are supposed to do a sentinel lymph node biopsy. And on the basis of considering that it's a sentinel lymph node biopsy positive, we will proceed to a formal axillary dissection where we remove level 1 to level 2 lymph node. Always level 3 lymph node we remove if there is a bulky tumor in the level 1 and level 2 region. So this specimen, which is now has a MRM done, will go again to the pathologist.
I think, sir, would you like to do a frozen section here?
Yeah. Obviously, if we have the luxury of a frozen section, obviously that's a very good idea, good thing to do it. But then primarily frozen section we do when we are, doing a BCT.
Yeah, right.
Yeah. When we are not doing a BCT, we know that this is the extent of excision we are going to go ahead. So in that case, we don't need a frozen section. But yes, obviously, when we have a BCT planned and when we are doing a
when you are doing a sentinel lymph node biopsy, you have to do that with the frozen section.
So we have to have your help there in during the surgery also. So that sentinel for biopsy again will go to the pathologist, and the pathologist, Dr. Praveen, will be telling me on phone that whether the lymph node is positive or negative, and depending on that, I'll be proceeding on a formal lymph node dissection.
I think that here comes again a general pathology. Suppose, guys, you don't have a luxury of doing that sentinel lymph node biopsy, and just by having your gut feeling, you remove the lymph node. The entire arm cannot drain the lymphatic drainage, so the entire arm will become lymphadenous. Right, so it will develop the lymphedema. So this is one of the advantage you can do if you have a luxury, obviously.
Yeah. Obviously, that is why before proceeding to a lymph node dissection, proper lymph node dissection in breast, they say that if there is no contraindication to a sentinel node biopsy, and if there are indication of sentinel node biopsy there, we have to proceed to a sentinel node biopsy before we actually get on to a proper axillary dissection, because that has a consequence.
Right.
And once we have a specimen with us, we will send it to you, and on the basis of the status of the margin and the status of the lymph node, will decide the further line of management. If we have a chemotherapy, we have radiotherapy, we have various target therapies also. So depending on the hormone receptor status, depending on the HER2, you already told me it's negative. So since it's a hormone receptor positive thing, so I can offer this patient a hormone therapy. Now, depending on the margin status and the lymph node status, I have to decide on the chemotherapy and the radiotherapy. So I would definitely need your help on deciding about the further line of management.
So like, sir, what is the basic reason of doing a ER positive or a PR positive or a HER2? How do you manage the case according to that?
Basically, ER, PR positive and HER2 new status is going to help us in two ways primarily. One way it going to help us is in deciding the treatment. Second way, it is going to help us in deciding the prognosis. So prognosticating a patient, telling the patient that what is a survival in this kind of scenario is very, very important, because the patients are already shaken with a malignancy when they come to know that they are suffering from malignancy. So we should be in a position to tell them that this is how these kind of patients do in future. So that is very important for the patient also to know. So that way they get motivated also, right? So for that prognostic thing, we need to have this ER/PR status there. And this is also very commonly checked question in exam, that what is the most important prognostic thing in carcinoma breast. And I keep saying that whenever we have a combined thing, a pathological, see, we have a 4 centimeter lesion here, right? So clinically that lesion is 4 centimeter, but when it goes to the pathologist, like when it comes to you, you will be seeing it in a under microscope. So it may be pathologically 4.5 or 5. So that pathological thing is actually more important than the clinical thing. And then the lymph node, which I say is negative on clinical examination, since I have done a lymphadenectomy, because the first lymph node turned out to be positive in sentinel lymph node biopsy, which I sent it to you. So that sentinel lymph node biopsy, I would like to know what is the status of the other lymph nodes. So that way I will be able to do a pathological staging. So when we have a combined staging, students, that has a very good prognostic value. But out of these various things like size, the lymph node status, and the grade also. Now, with the grading thing coming up, the grade of the tumor is very important to decide about a prognosis also. So, grade will also come to know through the final pathological specimen. So, out of these three, if we have to say which is the most important independent prognostic thing, I think you'll agree to this, Dr. Praveen, that the most important independent thing out of the three is the lymph node status. Lymph node status is the most important independent prognostic factor. But when we take it combined thing, it is always going to be
staging.
Better way of assessing the prognosis. So when it comes to grade, so how do we decide on the grading? Can you enlighten something?
Sir, grading is done in the terms of histopathology, and I used to remember this as PMT. Pre-medical test. So PMT means P is pleomorphism, M is mitosis, and T is tubule formation, right? So PMT. Let's remember this simple mnemonic PMT. Like, look at this. This is a tubule formation, right? This round thing are glands. So whenever a tumor is coming from a gland and is making a gland, so remember the definition of differentiation, the word differentiation, neoplasia, extent to which the tumor resembles tissue of origin. So out of these three, tell me which of them is looking like a gland. This is entirely looking like a gland. Look at these round glands.
I can also make out now, Dr. Praveen. Thank you so much. For me, actually, I'm not lying. For me, it was always
blue and pink, right? And I tell the class,
I can actually make out. Now I can discuss with my pathological team there. I can make out.
I can make out the glands, right? So look, this is entirely looking like a gland. Round things are the glands. So because this is actually looking at the tissue of origin, I will call this well differentiated. So one of the most common formation is the formation of tubules, that is glands here, right? This is okay, looking like a gland. This is a gland. This is not a gland. This is a gland. Look at this round one. This is a gland, but this is not a gland. So yes, I can call this is more differentiated. But look at this. Can you look at any glands? No, you can't, because you cannot make out any gland. For me, it is undifferentiated tumor. The one of the most important information you have is the tubule formation. When you look at the 40x, you will definitely be able to appreciate some mitosis figure. And because the cells are all different shape and size, it is called as pleomorphism. So if I told you PMT, pleomorphism, mitotic rate, and the tubule formation. In this case, just on basis of tubule formation, I can tell you this is well differentiated, moderate differentiated, and the poorly differentiated, it is called as Bloom. Richardson Grading System.
So once you tell me that it's a poorly differentiated thing, so I have to give this patient a chemotherapy, right? So once there is a high grade thing, so when the nuclear grade is high, we have to have a chemotherapy because ultimately we don't want these patients to have a recurrence.
Right.
You have told me that there is a negative margin tumor, but then we don't want this to come back.
Right.
So I have to have a chemotherapy in my armamentarium, and I'll give this patient a chemotherapy here. And now for giving a chemotherapy to a patient, we give a multi-drug chemotherapy, Dr. Praveen, and in that chemotherapy we prefer giving now ACT.
Okay.
Adramycin, cyclophosphamide, and taxane-based chemotherapy. Okay. If we don't, we can also give CAF here, but then preferred is now ACT. Means adramycin, cyclophosphamide, and the taxane-based chemotherapy. Okay. And since it is ERPR positive also, so the patient will be also very good responsive to hormone therapies, right? So depending on the age of the patient, we'll decide on the what type of hormone therapy we are going to give. But then this ERPR status has a very important role to decide about further line of management.
So guys, we can understand this like suppose a tumor is ER positive, it will or PR positive, it should respond to hormone therapy.
Yeah.
If a tumor is HER2 positive, it should respond to the HER2 receptor antagonist, that is Herceptin, trastuzumab. But if a tumor is ER negative, PR negative, and the HER2 negative, you cannot give the Herceptin, you cannot give the hormone therapy.
Yeah,
and then the treatment is
role of chemotherapy.
And therefore the last one, basal type, all three negative has the poorest prognosis of all of these morphological classifications.
Yeah. So this is very important. And so the take-home message for one thing before we sum up this, there is a very the gross confusion among students that what type of tumor, what type of carcinoma breast is there in BRCA1 gene mutation.
Right.
This question I keep getting, and there is a lot of confusion on this.
Sir, but tell me, would you do a genetic analysis in all the cases?
No, we don't do a genetic analysis in all the patients. But then if the patient belongs to a high risk group,
okay, right.
So there is a a separate criteria that who is a high risk patient. We keep discussing in our classes also that what is high risk patient. First we have to figure out whether the patient belongs to that high risk group or not. Once the patient belongs to a high risk group, it is always
better to do that.
Yeah, obviously, because the rest of the family is also having a risk of developing malignancy. So we can suggest them a prophylactic thing also to take care of the coming malignancy which they can have.
Right.
So in BRCA1,
so guys, so what happens is that look, these genes like P53 gene and the BRCA BRCA, we call this BRCA1 and BRCA2, these all are tumor suppressor genes. So suppose what happens is the EGFR, that is epidermal growth factor receptor, that is a proto-oncogene. And therefore, Sir told us that HER2 new amplification will cause a tumor. It's a proto-oncogene. When it becomes over-amplified, when it increases, it becomes oncogene. And oncogene function is to cause a cancer. So HER2 new amplification causes a cancer, but P53 mutation, that is absence, or a BRCA1, BRCA2 negative should become a cancer, right? So what happens is in the basal type, we talk about BRCA1. Right, and in the second type, that is the HER2 new positive, we call about P53 mutation. And the luminal type, we talk often about the BRCA1 mutation. That is one of the thing that is often
BRCA1
in the luminal type. In the luminal type, the triple negative is often, sorry, the BRCA1 is the basal type, very sorry. And the first one, that is the ER positive, is the BRCA2.
Yeah.
Very sorry. Okay. So I'll just tell it again. The basal type is BRCA1, the luminal type is BRCA2, and the HER2 new often is the P53 mutation. But let's understand why to look for the mutation. Sir, what do you say? Like suppose someone is BRCA1 mutated or a P53 mutation, like how does it change to you?
See, because these those patients who have a BRCA1 mutation, and since they have a poorly differentiated carcinomas, so they are going to behave very badly. So these malignancy come up early also, and they behave very aggressively also. So we have to also treat them aggressively. So it's very important to know the status of this. But then primarily to check for a BRCA mutation, we don't go to the extent to check for this BRCA mutation in a normal population. When it comes to a high risk, to talk about the management in our family members, we have to know the status of this
the mutations. Right. So I believe, friends, that there is, how do you approach a case? Let's have a small revision of the entire thing. Let's start it like the palpatory method. Sir, let's talk about a bit about palpation method here.
So see, what we are trying to tell you here is that integration of the things which is going to be the next coming thing which we can say in exam now. So just knowing the facts will not suffice the purpose. We have to understand the concept, because we can have various such questions where you are supposed to not only diagnose the condition, then according to the diagnosis you're supposed to manage that condition also. So just knowing the management that in a carcinoma breast we do this, that is not going to suffice the purpose. So we have to have the understanding of the pathology. Without understanding of the pathology, if the slide is there and we don't know the understanding of the pathology, we will not be able to reach to a diagnosis. Because if you look at the question stem, can we have the question stem again? If you look at the question stem, this 50-year-old patient has a variable consistency lump which is a 4 by 3 centimeter in size, right? And there is no lymph node in the axilla. It can be anything.
Yeah, it can be anything.
It can be anything.
It can be fibrilloma, it can be phyllodes.
Consistency to me, if I look at it at a glance, it looks like a phyllodes tumor, because right? Variable consistency. So we are now in a sea of various things. To know the exact thing, we have a slide also. So this is what they have done in the recent NEET exam, Dr. Praveen. They have a slide of papillary thyroid carcinoma, and then they ask that what is the management of this patient. So without knowing that orphan inei nuclei, how do they look like, right, I can't decide what is the management. So that integration is
very important to understand. And I think, sir, to understand this pathology, one should be having a very strong foundation of the second year.
Very important, very important. Without understanding the anatomy, without understanding the pathology, right, without understanding the physiology, we can't go to the medicine, we can't go to the surgery, we can't go to the other subjects, the clinical subject. The backbone of these clinical subjects is the good understanding of these basic science subjects. So let us summarize this here.
Yes, sir.
So whenever a patient of breast lump comes to us, as the question also says, that we are supposed to take a detailed history and do the clinical examination of the patient. Depending on the clinical examination and the detailed history, we then proceed to, we always do a triple assessment in breast. You all must be aware. We have a video on that also. So we should do a clinical examination, and then we should go to a radiological investigation. And after that, if required, we go to a tissue sampling, and then in that the preferred way of doing a tissue sampling, if there is a suspicion of malignancy, like there is a variable consistency here and there is a suspicion of malignancy, 50-year-old female coming to us, we should prefer doing a true cut biopsy. And on the basis of true cut biopsy, we decide about a further line of management. And once we have a tissue diagnosis in front of us, we are supposed to stage the patient. This patient, the information we have falls in a stage 2. Then according to the stage 2, what is a treatment protocol for stage 1, what is a treatment protocol for stage 2, what is a treatment protocol for stage 3 and stage 4, we ought to know. And then we have to, once we have done the complete treatment, then we should be in a position to prognosticate the patient also. We can prognosticate the patient before doing a surgery also, but then that will be a clinical staging and the histological picture. The confirmatory staging, the prognostic thing will happen when you do a pathological staging. Right. And then eventually we have to prognosticate and finally management of the patient. So these patients then are supposed to be followed up also. Right. So how are we going to follow up this patient once we have a management? We need to call them for clinical breast examination regularly, Dr. Praveen, for 6 monthly. Right. And then they should have their regular mammogram done annually also. So right. This is how we go ahead in any patient who comes to us with a breast lump and found to have a malignant
conditions. So I hope, friends, you have thoroughly understood the topic of breast, and you have thoroughly understood the concepts behind diagnosing something as carcinomas by clinical and the pathological diagnosis. And finally, you might have understood how to manage these cases. I am very hopeful that you will appreciate the effort that we are putting up for you. You will appreciate the amount of time that we need to understand and to take the topics in a easier manner. And we would be very happy if you could just put up some comments and the positive feedbacks or whatever feedbacks that you feel in the comment section below. It will really help us to be more and more prepared for the next upcoming topics, and can even put up some more topics, sir.
Yeah, definitely. Yeah. If let me tell you, this is enlightening for me also. So I would like to have some pathological
right. So that is very important. Like when you put our diagnosis to the surgeon and what he does, I believe that is the first time that I understand. It should come to the horse's mouth. So thanks a lot, friends. I hope that you will all appreciate and the effort that you're putting, and do put in the comment section below. Thank you.
Thank you. Bye-bye.